welcome everyone. Thanks for coming along. It's a bit of a tricky subject for a lot of people, but I hope what Nevis and I can share with you today will help you to understand continence. We're going to speak to you on a range of areas, starting with incontinence and what it is, risk factors for incontinence, who can help and what you can do for incontinence. We're going to address 5 healthy habits for bladders and bowels as a preventative measure and to help you invest in healthy bladders and bowels for your future. And Nevis will come on at the end and speak to you about challenges and case studies that will illustrate things a bit more clearly for you. So off we go. The Continence Foundation of Australia is the national peak body promoting bladder and bowel health in the country, and our vision is to have a community free of the stigma and restrictions of incontinence. The foundation is a not-for-profit organisation, and we're active in increasing the awareness on incontinence, educating on the treatment and management options for people affected by incontinence. We assist with a range of information and support services, and we provide online and paper resources to the general public, to carers, and to health workers. What we need to clear up at first is what incontinence is, for those who may be uncertain of this. Incontinence is the accidental loss of urine or bowel motion, and it's not normal. This can be either a small leak to complete loss of control. It can be occasionally or often, and in some cases there may also be issues with frequency. It's very common in Australia. There are 1 in 4 people over the age of 15 who are understood to have issues with incontinence. And for women, the situation is more marked. It's 1 in 3 women who've ever had a baby. So while it's common, incontinence is not normal. If you have poor bladder control, this may be marked by rushing to go to the toilet to pass urine. You may have accidental leakage of urine before you get to the toilet. You may be unable to hold on for long enough once you have the urge to go to the toilet. You may have a loss of urine on exertion, such as getting up from a bed or chair, or with laughing or coughing. You may wet the bed when you're asleep. You may have to go to the toilet frequently through the day. And you may find that you're waking up with the urge to go to the toilet more than once overnight. Now, by waking up to go to the toilet overnight, we mean not just waking up because you are unsettled and thinking, oh, I might as well go to the toilet. It's waking up with that urge. After you reach the age of 65, it's more common to wake up about twice a night. But anything over than that is showing that you have poor bladder control. You may also feel that your bladder's not emptying completely, and you may feel a poor urine flow. There are several different kinds of urinary incontinence, and I'll just briefly address them. They're called stress, overflow, urge, and functional incontinence. The first of these, stress, is probably one that most people are familiar with. You may find that you're leaking at the same time as physical activity, like coughing, sneezing, laughing, lifting, running, getting out of bed. The common cause for this is weak pelvic floor muscles, and it can be made worse if there's another medical condition going on, such as asthma, diabetes, or constipation. This stress incontinence is most common in younger women around birth childbirth and menopause. And it's uncommon for men, but it can happen after surgery, such as treatment for prostate cancer. However, usually 6 to 12 months with for men after prostate cancer surgery, it'll fix itself up. The next one is urge incontinence, and as you can guess by the name, it's the sudden urge to urinate, or you may leak before you reach the toilet. Sometimes this is referred to as an overactive bladder, and when this happens, your bladder may feel fuller than it actually is. This means that the bladder contracts too early when it's not very full and not when you want it to, and it may make you suddenly need the toilet and perhaps leak before you get there. Often you experience urge incontinence and also have the need to frequently pass urine, and you may wake up several times through the night to do so. This is called nocturia. Men are more likely to experience urge incontinence than stress incontinence. And some people have stress incontinence and urge incontinence. And this is called mixed incontinence. Surprise, surprise. Older women are more likely to experience mixed incontinence. The next one is called overflow incontinence. And if this is left untreated, there can be serious consequences. This is when you feel unable to empty your bladder. If this happens, you're strongly advised to contact your doctor. This may come on suddenly, and this is acute overflow incontinence. And what happens then is you should go to the doctor straight away, and they'll probably drain your bladder. You may experience chronic or long-term overflow incontinence, and this happens gradually over the months or years, and often you're unaware that it's happening. This may look like you're having symptoms such as having to pass urine frequently or straining to pass urine, having an intermittent stream, and never feeling you've completely emptied. Overflow incontinence is more common in men, largely due to an enlarged prostate gland, which presses the urethra, which carries the urine from the bladder to the outside world. And often men's prostate gets bigger as they age, and so it's quite a common thing. It's not so common for women, but it may happen after surgery or childbirth or prolapse. The next type of urinary incontinence is called functional incontinence, and this is where toilets can be difficult to use because of a mobility problem or another disability. So you may be having trouble reaching the toilet quickly or safely, or sitting on the toilet. You may find it difficult to remove or replace clothing, so you wet yourself before you're seated on the toilet. You may not be able to sit safely on the toilet or comfortably, or clean yourself or get off the toilet. But there are all sorts of devices and implements that can help this, such as these urinal bottles. There are different ones for men and women that can be used, and a toilet frame that sits over the toilet and can steady you. So even though your continence may be okay, you may be finding that your disability or your mobility issues are ending in you being incontinent, wetting yourself before reaching the toilet. Moving straight on to the bowels. If you've got poor bowel control, you may have trouble by having an accidental leak, not being ready to open your bowels, but it just happens. You may find that you're soiling your underclothes without being aware of them. you may be straining to empty your bowel. And if you have constipation a lot, that can show poor bowel control. And you may be unable to control wind. And by this, I don't mean if you've just had a big plate of baked beans or dal and suddenly it's Krakatoa. It means more trying really hard to not break wind in front of someone let's say you're trying to impress. So if you had that problem, that would show that you had poor control of your bowel. And there are lots of risk factors for poor bladder and bowel control. With pregnancy and childbirth, there's that extra weight put on your pelvic floor, and I'll show you some videos about the pelvic floor soon, and that'll describe what your pelvic floor looks like. And also when a woman gives birth to a child, that opens the vagina quite a lot and can stretch the muscles or strain them. When women go through menopause, their estrogen production is reduced, and this can mean a less elastic bladder, and the bladder gets irritated, and there's an urge to pass urine more frequently. Also, at menopause, often women put on extra weight around their stomach, and that can press down on the pelvic floor and strain it. And at menopause, as we get older, often other health problems start to kick in, and these can affect your bladder and bowel control. Being overweight, as I've just mentioned, is putting that extra stress on your pelvic floor muscles and can weaken them. If you're constipated a lot, this can affect bladder and bowel control. If you think about it, if you're constipated and you can't do a bowel movement, it means that that weight is being kept in your bowel. And because of the position of your bladder and bowel, it means that your bowel is pressing on your bladder. And so that can have a bit of a catch-22 effect. If you've got nerve damage or other health conditions, it can affect your bladder and bowel control. Nerve damage could be like multiple sclerosis or Parkinson's disorder or diabetes, and other health conditions such as arthritis, dementia, diabetes. If you've had a stroke, if you have heart or respiratory conditions, bladder cancer, asthma, or prostate problems. So there's a huge list. Weak pelvic floor muscles are a really common issue with bladder and bowel control. And if you've had surgery on that part of your body, so I'm thinking a prostatectomy, a removal of part of the bowel, if you've had a hysterectomy. Also, chemotherapy and radiotherapy can affect your bladder and bowel control. The other thing that's a risk factor is smoking, because this can increase your chance of developing incontinence, and if you have it, can make your incontinence worse. We know that smoking can cause chronic coughing, which places an enormous amount of pressure on the pelvic floor. And smoking actually irritates the bladder, which can cause symptoms of an overactive bladder. Moving right along, there are some conditions, though, that require immediate attention. If you find you suddenly can't pass urine, if you have, there may be, if this happens, there may be an infection or a medical emergency. You may need to have your bladder drained. If you have a stinging or burning sensation when you pass urine, you really should see a doctor, because this could be a urinary tract infection. And that can only be, that doesn't go away by itself. If you're constipated, if you're finding it really difficult to pass a bowel movement, or the bowel movement is really hard, you should have that seen too. And if you've had diarrhea that lasts for more than 24 hours, get yourself to the doctor or a hospital, because this could be masking something serious. You can easily become very dehydrated. And another thing that could happen there is you may be having food poisoning. So these things all need attention pretty quickly. And I want to encourage you not to put up with this. If left untreated, incontinence will usually get worse, not better. The first step is to have it properly assessed. You need to speak to your doctor or a continence professional if you experience any of the following symptoms. These are rushing to go to the toilet, not making it in time to get to the toilet, being unable to hold on, being unable to control passing wind, finding that you're leaking when you laugh, cough, or sneeze, having trouble passing urine, or straining to empty your bowel. And the people to see, if you're having trouble with incontinence, are your doctor. A doctor can provide medical assessments and treatment options, and can sign off on funding forms. A continence nurse advisor. These nurses are located within community organisations, hospitals, regional community centres, and continence resource centres. You can also call the National Continence Helpline, and they can give you advice about where to find a continence nurse advisor, or a continence physiotherapist, which is the next one on the list. A continence physiotherapist, sometimes called a women's health physiotherapist or a men's health physiotherapist, can assess pelvic floor function and tailor an exercise program to meet specific needs. All of these people have been trained in how to provide a diagnosis for incontinence and work out a management plan. You may feel embarrassed or ashamed to talk to the doctor or other health professional, but just keep in mind that these people see people with similar problems all the time. That's what they're there for. And incontinence can be better managed, treated, or cured. The pharmacist on the list is there because they can offer advice on medications that may be aggravating incontinence. They don't do continence assessments generally, but they can certainly help with medications. If you do have a continence assessment, you're likely to be asked about your bladder and bowel health. And this is along the lines of asking if you need to rush to go to the toilet, if you're leaking before you get there, if you're going to the toilet frequently through the day or several times at night, if you're noticing that your symptoms occur regularly or irregularly, and you can record information on these things before you go to have an assessment. This would also include if you notice that certain foods or drinks cause or worsen symptoms. At the assessment too, your medications are checked, so it's good to take a list of what medications you're on at the moment, and the doctor or continence nurse or physiotherapist may also do an examination just to work out what's going on. So any information you can record along these lines before you get to the assessment will really help. Okay, that's all the how to and what it looks like. Now I'm going to speak to you for a minute or 10 about some healthy habits that you can invest in to protect your bladders and bowels so that you can maintain your independence for as long as possible. And the first in this line, drink well, and the second and the third, eat well and be active, they're all things that we're really familiar with already. The last two, about your pelvic floor muscles and following certain toilet tips, are specific to bladders and bowels, so they may be a bit of new information. So here we go. It's really important to keep well hydrated, to drink fluid all through the day. And what I really want to impress on you is that water is the best drink. You can, as the picture shows, just walk out to the kitchen and get a free glass of water and drink to your heart's content. What's on the left-hand side of the screen is a diagram that shows you what's happening with the colour of your urine. So you know you're drinking enough water if your urine is pale yellow, like 1 or 2. As it goes down the drop and gets darker, number 5 would mean that you're dehydrated and you need to drink more water. Sometimes the colour of your urine can be red, and this could be because you've just had beetroot at lunch, or it could be sort of a bit green and smelly, and that may show that you've been eating asparagus. And some vitamin pills make your urine a different colour. And it's important to get into the habit of checking out the colour of your urine every now and then. The best way to know if you're drinking enough is to not become thirsty. When you exercise a lot, when it's hot, these are times when you have to drink more. There's not a set amount of liquid we have to drink all day. And there's also fluid found in a lot of food. So if you think about watermelon or cucumber, they're just loaded with water. But also there's fluid in soup, jelly, custard, anything really that's a bit wobbly, I suppose. Some fluids, however, we've got to be careful of overdoing because they can irritate your bladder. And these drinks often have caffeine in them, such as coffee, tea, cola, energy drinks. They're all high in caffeine. And alcohol and fizzy drinks, they should be avoided too. As Australians, I wouldn't say to you, you've got to cut out the alcohol, cut out the coffee and tea. But if you find that you're going to the toilet a lot to urinate and you are drinking quite a bit of those drinks, it could be good to think about switching to water or trying to even that out a bit more. Your bladder holds around 300 to 400 mils, and the best way to go to the toilet is when your bladder is full. It's not a good idea to go to the toilet just in case. This would mean you're going to urinate on the toilet between 4 to 6 times a day and not more than once overnight. I bet you're all thinking now. Now we're going to talk about eating well.
Just sorry, Lisa.
Yes.
Just a question on the previous slide.
Yes.
When we wake up and first go to the toilet, might the color of a urine be darker than during the day?
Very good. It can be. Yes, yes, because you've been lying down and it's becoming quite concentrated, and because you're not drinking while you're asleep, unless you're some kind of magician, that does make it more concentrated.
Thank you,
So,
Lisa.
yeah, I wouldn't, don't panic if it is darker first thing. Very good question. Thank you. Okay, back to eating, and a healthy balanced diet, including different fibre-rich foods with lots of fluids as well as exercise, is recommended to keep your bowels healthy and regular. Now, dietary fibre is only found in plant foods, and this means we've got to make sure we're having a wide range of fruit and vegetables and cereals and grain foods, nuts and seeds, that sort of thing. And you can get more fibre from a whole apple than you can get from an apple juice. So drinking juice is not a good way to get fibre. The whole food is much better. On the right hand of the screen, it shows you, gives you an idea of serve sizes that are recommended for your vegetable intake a day. Most people between the age of 19 and 50, we say it's good to eat 5 serves of vegetables, 2 serves of fruits, and 5 serves of cereals and grains a day. And a serve of vegetables is, for example, half a cup of carrots, half a cup of broccoli, a full cup of salad, and half a medium-sized potato. As I said before, it's really good to have lots of a wide variety of foods. So don't fill up your 5 serves with potato chips, because that's not going to help anything much at all. Fibre also protects against constipation and chronic diseases such as heart disease and type 2 diabetes, and can help you with weight control. And speaking of fibre, I now am showing you what's called the Bristol stool chart. And this was developed to show health professionals what a healthy stool or feces or bowel movement should look like. At the top of the screen, type 1, these are hard little small lumps, and they're very hard to pass. The one underneath it, type 2, is sausage shaped but really dry and lumpy. Those two types of stools probably mean the person's not drinking enough. Right down at the bottom of the screen, we've got types 5, 6, and 7. And these stools or bowel movements are likely to be showing what happens when a person doesn't eat enough fibre. So they're really soft. There are no, or they're quite ragged around the edges. And type 7 is entirely liquid. So diarrhea, it's really watery, and that's the one we said to be careful with. Type 3 and 4, they're ideal. Now, I want you to think of going to the Bunnings sausage sizzle and ordering a sausage sandwich. That's what an ideal stool should look like. It should be in one piece. Smooth is good, soft is good, and if it's got a few cracks on the outside, it's no big deal. But these types of bowel movements are easy to pass. And that's really what we should be looking for. With frequency for going to the toilet to do a bowel movement, there's no set number. Some people do 3 bowel movements in a day. Some people do 3 in a week. The number is not so important. What's important is what's regular for you. So if you go every day at breakfast time and then suddenly you haven't been at breakfast time for a week, that should give you an idea that things aren't working so well. Or if the look of your bowel movement suddenly changes from being a nice smooth sausage to small hard lumps that are hard to pass, that should give you the idea that things aren't right and maybe you should either adjust your diet, have more more to drink or more fibre if the stool is looking really sloppy, and see if that fixes things up. If you increase the fibre in your diet suddenly, if this talk makes you run into the kitchen and eat lots of apples and munch on a carrot and have some wholemeal bread, remember that it's important to increase the amount of fluid you're drinking, because you don't want all that good work to get stuck in your bowels. Moving right along.
Just on
Now,
that slide, I've got a couple of
yes,
questions. I'm really sorry.
yes, good. Yep.
How many milliliters equals to 1 cup? Is it around 250 is a question. Maybe some people just want to
250
hear it.
millilitres,
250
yep, for a cup.
milliliters, yeah. For a cup, very good. In regards to the Bristol stool chart, a question is, so type 2, 3 and 4 are the best. I think you said 3 and 4 would be
No, only
ideal.
3 and 4,
Yeah.
yes.
Very good, thank you.
Fatif, do you have any more information about that, the 250 cup? What?
I'll get back to you on that.
Okay, because let me just, here where it says it's not, it's to make it an easy guide. So if you think about, it doesn't matter, a teacup.
It's around 250.
Yeah,
1 cup in Australia is 250 mils.
That's right.
Half a cup is
That's
125, obviously. Yep.
And the Continence Foundation, and I'll speak about where you can find this in a minute, has some resources where you can download a little pamphlet on eating well for your bowel, and that goes into more depth on this area, so that might be helpful. Okay.
Thanks. And just another question just came. How much water should one drink a day?
There's not a set amount. You should, everyone's a different shape. They have a different metabolism. If you're working hard, you become thirsty more quickly. A good, we as health professionals, we don't say drink 2 litres of water a day. It's just not, there's no evidence behind that. You should be drinking enough so that you don't become thirsty, and so that your urine is pale yellow, pale straw.
So keeping an eye on that urine colour is a good indication.
Yeah. And also, you know, I feel thirsty now because I'm yabbering away, and I've got a glass of water, of course, by me that I keep sipping from, and that sort of helps me. And I can feel myself becoming thirsty. So when I feel that, I drink something straight away. It's recommended that we do 30 minutes of exercise daily. Now, this is pretty, it's a broad recommendation. All movement counts and helps to keep you regular. You can do things like gardening, walking quickly, hanging out the washing, dancing, playing, anything. 5 minutes here and 10 minutes there can add up to that 30 minutes a day. It also helps to maintain a healthy weight. It can work towards increasing your energy levels and improving blood circulation. It can help to make your bones stronger and your muscles and joints, and can help with overall balance and fitness. These things are important generally. If you can exercise so that you work up a bit of huff and puff, that's even better. Sometimes people may want to see an exercise physiotherapist, not physiotherapist, a trainer, or join a walking group, something like that. And community health services often can help with this. And the Health Foundation has a website and an app you can link to for walking groups in your state. You don't have to join a gym or go wild, but any sort of opportunity that you can exercise, you should really take it. And now, as promised, let's talk about the pelvic floor, because this is probably something a lot of you aren't terribly aware of. As you can see, both men and women have a pelvic floor, and I've got an animation in a minute that'll show you a bit more of how this actually looks. Your pelvic floor muscles, like your arms or legs or stomach muscles, can be exercised and become stronger when exercised regularly. And if you can keep your pelvic floor muscles toned, this can help with bladder and bowel control so that you're less likely to accidentally leak. Some of the things that can put a strain on your pelvic floor muscles are things like carrying extra weight, coughing, lifting heavy things, and being pregnant. Strong pelvic floor muscles can also keep your bladder and bowel from leaking and improve your sexual function. It's recommended that we do the exercises 3 times a day for only 2 minutes. And a continence physiotherapist can teach you how to do the pelvic floor exercises correctly. Now, I have 2 animations, one for men and one for women, and you can watch them both. But I think we may just run one so that we get better value out of the time. And I'll give you the link to watch the other. So let's watch the one on women.
The pelvic floor is the base of the group of muscles referred to as your core. These muscles are located in your pelvis and stretch like a hammock from the pubic bone at the front to the tailbone at the back and from side to side. They support the bladder, bowel and uterus, and play an important role in bladder and bowel control and sexual function. If your pelvic floor muscles don't work well, you may leak when you do things like coughing, sneezing, lifting, laughing, or exercising. To stop this from happening, you need to switch on your pelvic floor muscles. To switch on the pelvic floor muscles, you need to squeeze and draw in the muscles around your vagina, as if you are trying to stop the flow of urine. Lift them up inside. Breathe normally. Don't hold your breath or tighten your buttocks. Then let go and relax the pelvic floor muscles completely. Notice as you tighten and lift your pelvic floor muscles, they tighten and close around the anal passage, vagina, and urethra. By exercising the pelvic floor regularly, you will train your muscles to work automatically when they are needed.
There is also, through the Continence Foundation, we have a website called pelvicfloorfirst.org.au, and that is an app that can be put onto a mobile phone or a tablet and helps with keeping you on top of exercising safely for your pelvic floor.
Just a couple of questions on
yes.
that, if that's okay.
Yeah.
Are there any effects to the pelvic floor if a woman has had a hysterectomy?
There can be. Something like that, though, is best determined by a specialist. A pelvic floor physiotherapist sometimes can tell, or a continence nurse. That's more a question for a continence assessment.
And just another one, from what
Yes.
age the pelvic floor exercises is recommended? I know it's strongly recommended after giving birth for women.
Yeah, look, it's one of those things, a lot of people don't know about it, but we know that even young people who exercise really vigorously, gymnasts and trampolinists, they have problems with their continence because their pelvic floor muscles are damaged when they're exercising really frantically. And men also, it's recommended for men to not wait until they have prostate surgery when, or, you know, if they have prostate surgery, to start doing pelvic floor muscles, because if their muscles are toned before they go into surgery, they have better recovery rates. I think the big thing here, Fatif, is you can't see your pelvic floor muscles, so you don't know how they're doing. If you can get into the habit of toning them, keeping them toned at any age, it would be beneficial.
Just one thing, it's actually recommended to do pelvic floor muscles before you fall pregnant, because you want the muscles to be strong enough to carry the added weight of the baby and before childbirth. So it's actually a good preventative measure before you fall
Very
pregnant.
good. Yes.
Not
Thank you, Nevis. Last
Very good.
tip for keeping your bladder and bowel in good shape is to not go just in case or hover over the toilet. It's really much better for you to sit on the toilet and wait until you need to go to the toilet before you urinate or open your bowels. Getting into position refers to that diagram on the right. If you can get your feet a little bit elevated so that your knees are higher than your hips, and put your elbows on your knees and lean forward a bit, that actually helps with the anorectal angle. If you think of all the people, and makes it easier to go to the toilet. If you think of through history, all the people who squatted, you know, we weren't Adam and Eve, or, you know, the beginners of creation didn't come with the toilet included. So that's a good tip for making it easier. It's good to empty completely when you go to the toilet. So don't hold back. You won't get any interest on it. Let it all out. And it's important to wipe your bottom from the front to the back. If you wipe from the back to the front, you may cause a bit of contamination. With women especially, this can result in urinary tract infections, because in a woman's anatomy, her urethra is much shorter than a man's. So contamination has less of a journey to the bladder, shall we say. Now, for general interest, I want to show you the National Public Toilet Map. I don't know if any of you have seen this before. You can download a free app onto a mobile phone or a computer, and it will show you where the public toilets in the area are. You just type in an address or where you are, and it'll bring up a screen, and you can filter for things like if there's a change table, if there's wheelchair access, things like that. This diagram shows Mindle Beach in Darwin, and there are a lot of public toilets there. So I can't promise you that you'll always have a view of many toilets to choose from, but it does mean that the over 19,000 public toilets that are on the map will be accessible easily to you. And if you're looking after someone with a bladder or bowel problem. That's really important. Okay, the Continence Foundation has a website that's our main resource, and you can go onto this and find all sorts of information and literature on bladder and bowel health. There are things on females and males. There are areas for health professionals. There's a really good listing for information in 29 other languages than English, and you can go straight to a page and get all the information either spoken, which is good if a person's not literate in another language, and you can order resources or download information from the website. There are also little videos embedded in different pages. It's really worth having a look at. Now, the jewel in the crown for the foundation is the National Continence Helpline. This is a free and confidential service staffed by continence nurses who are all very experienced and still work clinically. They'll take your call and speak to you about any issues you've got with your continence. Sometimes it's just a matter of talking you through your diet, and they can do that. They can also help you with how to get financial help if you need continence products. You can only access financial help for continence products if you've had a continence assessment. So that's worth understanding. But a call to these nurses can give you the first step in a journey to making yourself better. And I'd encourage you, if you know anyone who's got a problem with incontinence, to get onto the helpline. And that number is 1800 33 0066. There's also a service where you can access the helpline if English isn't your first language. And to do this, you call TIS, the translating service, on 131450, nominate the language you'd like to speak in, and then ask the translator to call the helpline on 1800 33 0066. Now, you can rest from my scratchy voice, and I'm going to hand over to Nevis, who's going to speak to you about challenges for interpreters.
How long does it take approximately to strengthen a weak pelvic muscle is a question.
It's around, generally, everyone's different, their situation is different, but generally it's thought to be around 2 months. So don't expect, if you suddenly start to do the exercises, that you're doing them properly and that it will have an immediate effect. And the other thing is the Continence Foundation also has a YouTube channel. And if you go to the Continence Foundation on YouTube, you'll find those 2 pelvic floor animations on that.
Thank you very much, Lisa. Like I said, there's quite a lot of comments and questions coming in. We will get back to you in an FAQ format. We are kind of running out of time.
Okay, let's get on to
Thank you.
Nevis.
Now, over to Nevis Zarafe, who's going to take us through to the next part of the webinar. Thank you very much, Lisa, for this amazingly informative session. I think we know a lot more about bowel and bladder movements as well as incontinence than we did an hour ago. So thank you very much.
Cheers.
Lisa. All right, so now we're going to talk about some challenges that interpreters might face with Nevis. Thank you, Nevis.
That's right. That's right. Thank you, Fatif, and thank you, Lisa. That was quite good, and I hope you all found that quite informative. Before we tackle the case studies, I just wanted to bring to your attention that when you do interpret on subjects relating to incontinence, you will find challenges. But I just want to bring to your attention that whenever there is a continence assessment, you're dealing with personal and very private issues. they discussed during the session with the health professional. So, and these issues are often not told, they haven't told this to anyone, not even their own family members. So it's very private. And a lot of people wait until it's the last resource where they cannot even manage the continence themselves. So a lot of them try to manage as best as they could with, you know, in the best way they know how. But when that no longer works, they then go and get help. So you've got to actually be mindful of the emotional challenges that the client might be facing, particularly if it's their first visit and they haven't told anyone. So once again, just understand interpretation needs to be done respectfully and sensitively. Understand the emotional challenges that these clients are facing, and then you'll and then hopefully it will be all good from there on. Now let's look at some case studies, and these studies were actually created from actual interpreter related experiences. So the first one is, let me read it for you. An interpreter is interpreting for a man at a continence assessment interview who has had a transurethral resection of the prostate procedure, otherwise known as TURP. The continence nurse is asking the man about what exactly is happening when he goes to the toilet and if there is any leakage throughout the day and night. The nurse is also asking the man about his sexual activities, and the word penis is used regularly. The interpreter, in response, shows facial expressions that he is shocked when he hears the word penis and is feeling uncomfortable interpreting their questions about the man's sexual activities. The man, who was already distressed, seems further distressed and embarrassed about the interpreter's reactions. So what are the main issues here? What ethical principles apply, and what would you do?
All right, feel free to comment. So what are the main issues here in this case scenario? From the AUSIT Code of Ethics, which ethical principles do you think apply here? What would you do? So Nevis, you're right. I have done quite a few of these assessments as well, and things can get quite tricky. You've got people who are already quite sensitive about the matter, and then, you know, if the interpreter is showing facial expressions of shock, for example, it might make it even further uncomfortable for the patient there. Just some comments coming in. I'll read those out if you like.
Okay. Yep.
So, discretion, treat like any other body part. Explain it as it is. It's very important to the client to know. The interpreter is not trained to interpret in these situations. I'm quite comfortable, no issues for me. Okay, they're just coming in now. Very difficult in our language.
Right.
There are lots of rude insults using the penis as a word. Shouldn't show any reaction and interpret normally. Interpreter must be professional at all times and must not be judgmental, are some of the comments here.
Oh, great. Oh, well, that's great. That's awesome, because interpreter not only has to be aware of the client's sensitivities, but you have to be aware of your own. And it sounds like many of you actually are quite comfortable with the anatomy and certain words spoken, so which is awesome. But if there is ever the occasion where you do get embarrassed, try not to show it. So the point is to be conscious of your reactions and try not to show it, because you don't want to add to the client's feeling even more uncomfortable. And a good way to combat this is to be informed, and once you're informed and you've addressed the topic, you become more comfortable with the topic. So it sounds like we're on the right path here. So the next scenario.
Let me just make a few comments, sorry, on that one, regards to the ethical principles. So yes, definitely we'll need to be informed and comfortable with the topic. Don't show shock, distress, embarrassment. Now, this all goes under professional conduct, as well as accuracy. As you would know, interpreters, as a code of ethics, we need to interpret everything the way it is said, what is said, without adding or omitting anything. So if for whatever reason some things aren't interpreted, this would be against accuracy. So we need to make sure that we interpret everything, and you might want to have a look at your terminology as well. I find that using more technical terminology, using the word penis for in Turkish as penis, for example, might be more professional and make it a little bit less, make it sound a little less rude. So you might even want to work on your terminology with different registers for body parts. And of course, impartiality is might be compromised here as well. We need to make sure that we stay professionally detached and we don't get emotionally involved or show opinion. And it's important to know that sometimes, even though when we don't say things, we might show emotion and opinion on our faces. Just we need to be aware of the fact that we need to hide those emotions and opinions on our faces as well, because that would go against the impartiality too. Thank you very much, Lisa.
Okay, in this scenario, an interpreter is interpreting for an elderly person and a continence nurse. The interpreter seems to be struggling with the meaning transfer of some key continence terminology, such as prolapse, bladder, bowel movement, sphincter. Both the patient and the continence nurse are not sure that their utterances are being correctly conveyed. So what do you think the main issue is here, and what would you do? And this sort of touches on what Fatif was just saying before about the accuracy in your interpretation.
All right, so what are the main issues here? Interpreters, translators that are here today, which ethical principles apply, and what would you do in this case? What would you do before? What would you do during? What would you do after? Okay, asking for clarification is definitely a strategy. Okay, but what else can be done here beforehand? Accuracy is very important. That's correct. Accuracy is the main principle here. What else? What other principle can we think of in regards to working on our terminology, for example? What are we doing here today, for example? Being prepared is very, very important. That's correct. All right.
Just seem to know to come up with the right answer.
Knowing the right terminology, speaking to the patient before seeing the doctor. So a briefing would definitely be helpful, but we would probably get more from the professional than the patient. To ask the nurse for clarifications, that's a good strategy. Briefing, yes. There we go. PD, definitely. PD is a very, very important one. So professional development is one of the principles of the AUSIT Code of Ethics, as you are well aware. And yes, that would also be at hand here as well. All right, let's have a look at some of the points in this case scenario. Nevis, what do you think?
Yes. So as we identified, the lack of knowledge of the medical terminology is the issue at hand. That if you don't understand the terminology, you can't accurately translate the discussion or convey the right messages. So what is the meaning of prolapse? What bladder or bowel? How would you describe those in language? So it's important to prepare, do your research, find glossaries. We have actually revised or updated a fact sheet that we have for interpreters on what to expect during a continence assessment. And this includes a glossary. So it includes a definition in simple terms of a bladder, of a bowel, of a prolapse, of a prostate, and so forth. So a link will be sent out to you after this presentation sometime with this, that will lead you to this fact sheet and to a few other resources we have available as well. So it's also important, we mentioned being prepared, doing your research and finding glossary, but it's also important for an interpreter to get in contact or in touch with the health professional beforehand to understand the medical context, the condition at hand. So, and the individual, every situation, every client has a situation that's individual to them, so it may differ from another client. So you need to talk to the health professional and find out exactly what's going on, and request a briefing. Learn to understand the meaning of the medical terms, and this will help to facilitate what's the best way to translate, particularly if there's no equivalent word in language. So once again, be informed and comfortable with the actual topic.
Thank you, Nevis. Now, yes, let's have a look at those ethical principles, accuracy and professional development, as well as maintaining professional relationships. I see some of the comments coming through saying that, yes, we could ask for clarifications. Yes, that is a strategy, but when we are going to a continence job and we know of that, we should prepare for that particular job. Every job that we get, depending, doesn't matter, you know, what field and area it's in, even if we are very experienced in that field, we should always do preparation for each and every job, doing research, understanding, like we are doing here today, understanding what the setting is about, and then building, even if it's a mini glossary, thinking about what kind of terms, what kind of words might come up. And then, of course, you know, you've got to think about register. How is it going to be interpreted for more an educated person, and how is it going to be interpreted for someone who hasn't had a lot of education? Okay, so there's going to be different words, different terminology used for the different kind of patients that there might be there. Requesting a briefing is actually a part of the AUSIT Code of Ethics. It is under maintaining professional relationships, to be precise, 7.4 of the Code of Conduct. And it's very important that we do have a briefing with the healthcare professional so that we get a little bit of a context, we understand what is going to be discussed, and if there are going to be some terminologies, we can sort those out before we actually go in. But then after you've done your preparation, after you've had your briefing, if there is, of course, still things that we don't understand, some terminology that we don't understand, of course, then we can ask for clarification from the healthcare professional. But I think instead of asking for clarification constantly, it's very important that we do the preparation, that we build our glossaries, that we are having the briefing, and then using that clarification as the last resort during that assignment.
That's right. That's right. So let's go on to the next scenario, because I know we're running short on time. Okay, in this situation, a continence nurse has booked an interpreter to interpret remotely by telephone. While interpreting, there's a lot of background noise coming from the interpreter's line. The nurse also hears tram stop numbers being called out in the background. Halfway through the session, the interpreter asks the speaker to hold on, or to hold as he or she has to take another call. So what are the main issues here, and what would you do? And I'm sure this doesn't happen to many of you, but this has actually happened. So let me just stress that point, that we need to tackle this.
I was just going to say that, Nevis. Now, although I'm sure that our interpreters here today might look at this and go, oh, you know, what a silly case scenario. Who would do something like that?
That's not what I'm interpreting.
This has actually happened. Unfortunately, this has actually happened, and probably more than once, enough to make a case scenario out of it. So let's totally unprofessional. Yes, very good. Be professional and make sure it is a quiet place. So let's think about which of the ethical principles are being compromised. You know, what happens if we are in a public area and we're talking about people's health issues, you know, or for any interpreting job, regardless of what the topic might be. What happens when you're interpreting in a public area? Yes, professional conduct, definitely. But let's think, instead of professional conduct, in addition to professional conduct, what is one of the main ones here? What the main principle? Yes, thank you. Confidentiality. Confidentiality is definitely one of the big ethical principles here that is being compromised. I want to point out that confidentiality, not only are you compromising a code of ethics principle, okay, but we are also breaking the law in this case. It is one of those principles that is binding, that might actually get you in trouble if you break that principle. Okay, so there's the Privacy Act. There's also federal acts as well as statewide acts that go. If you compromise this particular ethical principle, not only will you be breaking the AUSIT Code of Ethics Code, but you'll also be breaking the law. So this one is a very, very important one to understand. So yes, professional conduct, confidentiality, patient privacy, all of these are indeed correct. Thank you, Nevis.
Okay, so look, what are the answer to this? None of it's a surprise. You know, minimize the background noise. Obviously, do it in a private place, but minimize the background noise. So if telephone interpreting or video interpreting, that if there's a hearing impairment by the client, they can hear you. Ensure the conversation is not overheard by others. That's what we spoke about before, keeping it confidential. And do not take other calls or handle your phone for anything else but for the call that you're on.
If you get on the AUSIT website, and you will also find hyperlinks when we do send you out the slides as well for the AUSIT recommended telephone interpreting protocols, as well as the newly released AUSIT recommended remote video interpreting protocols, which AUSIT released last year as well. So please have a look at those protocols there. In addition to that, we also have a free video remote interpreting short course. So get onto our website, Conversations Interpreting and Translating, and then you'll find a self-paced free online short course there, which will take you through exactly what video remote interpreting is and some of the challenges and strategies that lies within a video remote interpreting. So lots of free resources there for you. Please make sure to check those out. Thank you very much, Nevis.
Okay, now look, there are some other challenges that interpreters will face, particularly when a physical examination is required. And during a continence assessment, more often than not, a physical examination is required. This is where the client will be taken behind a curtain in a hospital or clinic room. If it's a home visit, the client will be taken into a bedroom for the examination. So where do you stand in these situations? Have you ever been in this sort of situation before? But if you have, or if you haven't, where would you stand in these situations? And we recommend that you stand just outside the curtained area or just outside the room, so you can still hear the conversation and interpret. And sometimes you may need to have your back turned as well, just for added safety and privacy. Okay, any other comments there for Tiff? No?
Yep, behind the curtain and turn our back is one of them.
Yep.
Yep. So.
Okay. The next challenge, or another challenge, is prompt and accurate interpretation. During an examination, there are steps involved, and quick translation is required in real time. So when the instruction is given, squeeze and hold for as long as you can. This needs to be promptly and concisely interpreted, as the health professional needs to assess the response of the client to that particular instruction. So if there's a long delay between an instruction and the client response, it can be difficult for the health professional to make an accurate assessment. Basically, yeah, we can't have that long delay. The interpreter needs to know the client's response to a particular instruction. Okay. And
so just on that one, it might even be worth thinking about switching to the chuchotage mode, so interpreting in the simultaneous mode when these particular physical examinations are being conducted. And you might just, as the interpreter, say, now I'll be interpreting in the simultaneous mode, because the healthcare professional, as Nevis is saying, will need real-time responses to the instructions. So it might definitely be worth considering switching from the consecutive mode to the simultaneous mode in this case, so that responses can be given more quickly. And we can actually talk about this in our introduction. We can say we might be switching from the consecutive mode to the simultaneous mode, so that the service users are prepared for that, because sometimes it can put people off. But that is definitely one strategy that we can employ, is switching from the consecutive mode to the simultaneous mode in this particular situation.
And the last slide is the other possible challenges are related to behavioural and mental health issues. Particularly when working in aged care settings, you might find some clients who do have cognitive or behavioural issues. And so in these cases, try not to aggravate the client and keep them calm. And so the advice that I probably will give you is follow the actions and the manner of the health professional. If you follow their actions and follow their demeanour, you'll basically hopefully keep the client calm, because in many cases the health professional may know the client well. In some cases they don't, but in many cases hopefully they do. And detaching yourself from the situation while performing your role is ideal. So it's essential you meet with a health professional beforehand to understand what is expected and how to conduct yourself. And this is a time of preparation for yourself. In this time, you can also cover the main topics which will be addressed in the session with the client, what the client is like, and the sort of things that you can expect.
And within regard to the briefing, and I understand that interpreters might go from one job to job, you know, trying to fit as many jobs as possible. When we say briefing, we're not necessarily talking about a 15-20-minute meeting. You know, sometimes even if it's just a walk and talk, if it's a home assignment, you can just have a quick 2-3 minute talk on the front yard, for example, or if it's in a hospital or at a clinic, you know, as you're walking from the wait area to the room, you might have a quick walk and talk. Okay, so even if it's a 2-minute, 3-minute, very brief meeting, it is definitely going to aid in your final preparations for this particular assignment. You know, same thing with the debriefing. It doesn't have to take hours. So you can definitely, if you can come in a few, you know, ideally you should be there at least 15 minutes before the job. And if you can spare a few minutes of that time for the briefing, I think it would be beneficial for the interpreter, for the service provider, and of course, for the patient as well.
That's right. So hopefully these scenarios and some of the challenges that we have listed gives you an idea of what you could expect and how to prepare yourselves. And then you'll be, that will be the best way of going about it.
So, you know, I've got some comments saying most of the time briefing does not occur. So this is your responsibility more than anyone else's responsibility. We are trained interpreters, and we abide by the Aussie Code of Ethics, and it is in there. If someone just automatically doesn't come to you like the service provider and says, oh, okay, I'm going to give you a briefing, we need to ask for that briefing. You know, yes, there are service providers that are also very, very well trained out there, and you know, they'll come and tell you a little bit about the patient and what's going to be discussed. But you know, sometimes you are going to have people that are maybe not very well trained in this area, or that maybe are new to the field, and it is our responsibility. If you have a look at the Aussie Code of Ethics, maintaining professional relationships, it's our responsibility to actually tell our role, explain our role, and what an interpreter does not do, and also promote the interpreting profession as well. So I think we should drive that. We should be the one asking for the briefing. Like I said, even if it's just a walk and talk, minute, 2 minutes, there's a lot that can be said in a couple of minutes, okay? So don't expect for it to happen automatically. Someone's just going to come and give you a briefing. Ask for that briefing. It is your right. It is your duty to ask for that briefing. And trust me, you will definitely gain a lot from a briefing, and not just you, all parties involved. And you know, someone's asking me about do we have to notify the professional if we're switching modes? It's really good to do that at the start. You might just say in your introduction, you know, my name is so and so, I'll be interpreting for you today. Please speak to each other directly. I'll be interpreting everything, but everything will be kept confidential. From time to time, I might be switching to the simultaneous mode, depending on the situation, okay? And when there is an examination and then you switch into the simultaneous mode, people are expecting that. But let's say you forgot to do it in your introduction, you might just quickly intervene as the interpreter when the examination starts and say, interpreter speaking, I will now switch to the simultaneous mode during the examination so that the instructions are interpreted in real time. And of course, you will notify the non-English speaker about this as well. So you'll just interpret that into your load as well, okay? So, you know, you can do it just before the examination starts, but I think it's a really, really good strategy to switch from consecutive mode to the simultaneous mode during the examination. And then afterwards, you can go back into the consecutive mode. Asking for a briefing in front of the non-English speaker is very difficult, okay? And professionals never have time for briefings. look, I've been practicing interpreting for a long time, and I still practice interpreting. To be honest with you, I've always asked for briefings, and more often than not, I have received it. So we just have to insist on this, and the more we do it, and I think the professionals are going to get used to it as well. It's of course best not to necessarily have that briefing before in front of the non-English speaker, because then everything has to be interpreted for the other party as well. Okay, so if we can do the briefing with the professional before we actually go either into the house or into the ward, or have a quick chat with the professional before we actually see the patient, that's of course going to be ideal. Okay, some of the other questions are coming through. Yeah,
I think you raise a good point, Fatif, is that a lot of some health professionals have never worked with an interpreter, so they do need to be guided in some way. So as long as you know your role perfectly, then you can probably provide guidance to the interpreter how to work with you. Sorry, health professional to work with you.
That's right, you know, and there's thousands of people out there, including interpreters and healthcare professionals working with this field, and you're going to have some very experienced ones, and then you're going to have some not so experienced ones, you know, and you're going to have some that are great at their jobs, and you're going to have some that are not so great and do well in their jobs, but not the best at it. Okay, so we know that we work with people, and when people are involved, nothing's going to be as easy as black and white. Nothing's going to be as it is on paper. Okay, so we need to make sure that we understand this. And yes, sometimes we're going to have professionals that know exactly how to work with an interpreter, who've done it for years. And sometimes you might have someone, like we said, who's just started or who's never had the pleasure of working with an interpreter. And it's a collaborative thing, you know. Sometimes we'll learn from them, like we are learning from you today, Lisa and Nevis. And sometimes they're going to learn from us. And trust me, it's all for the benefit of not just the interpreter, not just the service provider, not just the patient, but for everyone. I think if we do have that briefing, the outcome is going to be much better for all parties involved. Nevis and Lisa, what would you say?
I totally agree that, you know, it's a learning curve for everyone involved, and if we can all work collaboratively, that will make the end outcome on, you know, as positive as can be, because what we want is the correct information to be conveyed, so people can make the right decisions and come out with the right understanding of what the diagnosis or the treatment is. So by all parties. So that's what we want. We want clear communication, and it to be as comfortable as it can possibly be, particularly in this sort of situation where it is uncomfortable. The actual topic can be uncomfortable. So if we can make it as comfortable as possible, that's ideal.
That's
and
correct.
we have to keep in mind too that the way health professionals are working now is around person-centered care. So it's all about the health professionals getting the best information and service to the people they're dealing with. And if they're not on top of that, they should be. And that includes, you know, your role in it as interpreters.
And I think training is an ongoing thing for all of our lives. So, you know, we'll learn from professionals, and professionals will learn from us. Big thank you to Lisa and Nevis for today's webinar.